Hey everybody, welcome back to Pulm Peeps. Today we have another Pulm PEEPs Pearls episode for you, where Christina and I just sort of talk through a topic and try to give you some good takeaway points. Christina, how you doing today?
Doing well, Furf. Really looking forward to this episode, right? I think 15 minutes is hopefully a sweet spot to get some high yield information out.
15 minutes is always our ambitious goal. I don't think we usually hit it. We're usually like in the 17 to 18 minute mark, but hey, we love talking to each other. What can we say? So today we're going to be talking about a test and a topic that comes up a lot. It shows up all the times in papers and guidelines, but it's a little mysterious because we actually don't use it as often as we talk about it. And this is the methacholine challenge for asthma diagnosis. So let's set up a case like we normally do. We have a 32-year-old teacher. She's had 6 months of episodic wheezing and coughing. Her spirometry is totally normal when she's been tested. And she had a bronchodilator test with spirometry that was negative, meaning that she didn't have a 12% change or a 200 milliliter change in her FEV1 or her FVC. She also got a fractional exhaled nitric oxide test to look and see if she had evidence there of asthma or hyperactivity, and this was borderline. She has tried an as needed and standing LABA and ICS, a long-acting beta agonist and inhaled corticosteroid inhaler, based as we're supposed to, based on our current treatment and guidelines. But the effect of that is like equivocal. You know, she sort of thinks maybe sometimes she feels a little better with it, but doesn't always work, and she still has the symptoms. And she's pretty frustrated by her symptoms and that no one can definitively tell her if she has asthma or not since this has started. So the question comes up about, should we send this patient for a methacholine challenge test? So today, this is going to be Monty's Pearl on when and how we use this test. So let's start from the top. What is a methacholine challenge actually measuring, and how good is this a test is this for asthma?
Yeah, Furf, such a great question, right? And I think understanding exactly what is a methacholine challenge, and to remind ourselves, that's a direct bronchial provocation test of airway hyperresponsiveness. On our prior episodes, we've talked about how important this airway hyperresponsiveness is in asthma. Is really one of the core physiologic features of the disease. I think one important pearl right off the bat is to keep in mind that any one of us, Furf can have it, I can have it, you can have it if you're listening today, you can have airway bronchoconstriction at high enough concentrations of methacholine. So what we're looking for is an abnormal threshold in the testing. And what we really care about is the endpoint is the PC20. And what is that? You may see it on boards or during your fellowship training or residency training. You may be exposed to this. But what is PC20? That is actually the concentration that causes a 20% fall in FEV1. So in adults, a PC20 at or below 8 to 16 milligrams per milliliter is going to be considered abnormal. So that's kind of like the stage. What is a test actually testing? What do we actually care about as far as numerical values from the test? But Furf, to your second question, in terms of test performance, meta-analysis have showed pooled sensitivity around 60% and specificity around 90%. But in real-world diagnostic cohorts, we're more often seeing sensitivities in the 55 to 60% range, and specificity can be anywhere from the mid-50s up to 100%. But this really depends on who you're testing, the protocol being used, and specifically what threshold your lab is using for an abnormal. So overall, it's not a perfect yes-no test, but it can really work well to be a test that's important as part of a broader diagnostic pathway, and definitely could be helpful for certain patients, such as the one in our case today.
Awesome. So it sounds like this test can certainly help a lot. And from what you said about those numbers, really it's in that sort of specificity area that I think this would be most helpful, in that if you're having a positive methacholine challenge test, we can be really confident that you have airway hyperreactivity. And a negative methacholine challenge really can rule out the diagnosis of asthma, given that high specificity. So this could be helpful in the right context. Let's talk a little bit about where this is going to actually go in your workup. So when we have a patient who has potentially asthma symptoms, we've all heard not everything that wheezes is asthma, but it could be. Where does methacholine actually fit in? Monty, when are you reaching for it when you're seeing patients who might have asthma?
Yeah, such a great question, Furf, and definitely not the first test that we're going to be grabbing to and talking about with our patients and putting in an order for. But it really is kind of in this sweet spot, as you said. A patient in our case, someone with asthma-like symptoms, but may have normal spirometry, no bronchodilator reversibility on PFTs. So in that group, methacholine tests may give you the highest sensitivity of the tools that we have and really help answer, is there airway hyperresponsiveness here or not? So the guidelines can differ in how they determine and when this test should be ordered. But I think overall, and what we want you to get from today is the patterns are going to be similar. And there's really kind of three-step approach to this. So number one, we still recommend, and the guidelines recommend, starting with spirometry and bronchodilator response as our patient had. Number two is going to be adding simple markers like FeNO or peak flow variability if available. Not all labs and institutions have FeNO or fractional exhaled nitric oxide, so that may not be possible in certain settings, but that's really kind of the second tier of how we're going to work this up. And then the third option is going to be out of 1 and 2, if the picture is still unclear, then I think that's an appropriate point and when we can recommend using the methacholine challenge as a next step.
Yeah, that totally makes sense. It's a test you reach for when your spirometry and bronchodilator response really haven't answered the question. Sometimes I'll even add in there, you may have tried empiric treatment, and if it feels like the patient responded, then that could be diagnostic in itself. But if you really don't know after that, then this is sort of your next step to lean on. Given the slight risk, which we'll talk about, the cost and maybe like the little bit of discomfort of the test, we wouldn't want it to be our first option, but it just might be necessary for some patients to make the diagnosis of asthma. It sounds like we might need it in this patient. So let's get into the logistics a little bit. If we're sending someone for a methacholine challenge, what actually matters about how the test is done and how we prep them? You said the sensitivity and specificity can vary. What are the things that matter in terms of the conduction of the test?
Yeah, again, another great question. And when I think about this, there's really two simple things that I try to think about before sending a patient to a methacholine test, and conversations we should be having with our patients. So one, how is the drug given? And two, what meds is the patient currently on that may impact the test results itself? So we'll start first on the technique side. The ERS guidelines now favor a tidal breathing approach over repeated deep inspiration breaths. So telling the patient, they're going to be guided on just breathe normally. We're going to get some results and data as you continue to do this. And the reason why is, big, deep breaths can be bronchoprotective and blunt a response. So having patients just breathe normally through the nebulizer tends to give you better sensitivity, especially in mild or well-controlled asthma. The second thing that I think about, what current medications is a patient on? What inhalers might they be taking that could impact the test? So it's always important to assess what the patient's currently taking and walk through any parameters that you want them to change before going through the methacholine test. So on the medication side, the main thing that we may get in trouble with is our bronchodilators still on board, right? So short-acting anticholinergics like ipratropium usually need about 12 hours before they wear off, but longer-acting agents like tiotropium can keep blocking methacholine for up to a week. So we typically aim to have a 7-day washout for LAMAs or long-acting muscarinic agents. So that's, I think, really important to keep in mind. Similarly, short-acting beta agonists typically need at least 6 hours, whereas LABAs are long-acting bronchodilator agonists about 24 hours, and ultra-long-acting beta agonists may even need closer to 48 hours. So it's really important to understand when your patients are taking them and really try to guide them and coach them on when they should and when they should not take these inhalers prior to the test itself. I will say, though, because I think it's going to be brought up, inhaled corticosteroids, leukotriene blockers, and antihistamines don't really have much effect on the test itself. So we'll usually recommend for patients to continue on those, and they don't have to hold them prior to the test. I think it's also important to note that there's also a known risk factor to withdrawing inhaled corticosteroids for patients with asthma, so we really try to avoid that. So I think overall, we want to be mindful, of when patients are taking things and when to hold them, as the numbers that I just said. If we miss those washout windows, though, specifically the llamas and labas, you can get a falsely negative study, and that's what we want to try to avoid. So, a very practical step is to spell out exactly what to hold and when for the patient and for the lab when you're ordering the test, and make sure the patient's going to get these instructions before they actually show up to the lab.
Yeah, absolutely. I mean, if we're digging deep for this a little bit next level test, we might as well get the right results out of it. You would not want to have to repeat it. And so detailed instructions makes a lot of sense so we can interpret it appropriately. All right, so we've prepped, we've done the test. When you get the results of this, it's not as simple as you might think. It doesn't just say a patient has asthma. You get a whole bunch of different charts with the different concentrations of methacholine. So how should we actually interpret the results once we have them and we're back in clinic?
Yeah. That's I like this question, Verb, because it brings me back to fellowship. We have a physiology rotation, and part of that rotation was being in the lab when someone went for the methacholine challenge and interpreting the results. And the first time I looked at it, I was like, "What am I? What am I looking at? I have no idea. What's the PC20?" But a negative methacholine challenge, what do we consider that to be? So that's going to be where the patient does not have a 20% fall in FEV1 at the highest concentration. So usually this is going to be PC20 greater than 16 milligrams per milliliter. If this occurs, this has a very high negative predictive value in symptomatic adults and makes current asthma very unlikely, assuming that the test was done properly. So I think, as you said, Furf, this is one of methacholine's biggest strengths. It's really an excellent rule-out test. I tend to think a positive test is going to be a little bit more nuanced, and you actually have to, as we do with testing, bring it back to the patient, look at the history, and try to put everything together. So airway hyperresponsiveness, though, even though it is characteristic of asthma, that's not the only diagnosis to consider. So we can still see positive methacholine tests in chronic cough, allergic rhinitis, COPD, and even a small percentage of otherwise healthy asymptomatic adults. So a positive methacholine test by itself does not equal 100% you definitely have asthma, right? We still need that clinical story, the typical variable respiratory symptoms, plus other objective markers like peak flow variability, FeNO, and response to inhaled corticosteroids.
Yeah. Another good reason why you should order this with some deliberation. You wouldn't just want to send a healthy patient for this. Then what would you do with a positive result if they'd otherwise have no symptoms of asthma? All great points. All right. Well, when you order a test like this, the first time I ordered one, I got a call from the PFD lab like, oh, is someone going to be around? Are you sure they can tolerate this? And so I think there's a lot of mysticism around the risks behind this. So let's talk about the potential adverse effects and risks for a methacholine challenge test and how safe or not safe it actually is.
Absolutely, Furf, and such an important topic, and definitely a question that our patients are going to be having. But the data actually shows that these tests are quite safe and that significant adverse effects are very rare. That being said, we are trying to induce bronchoconstriction, so a patient could have temporary breathing discomfort for sure, and that's something that I think that we have to keep in mind. Um, you know, it's rare, but it's possible to get severe bronchospasm. So a good rule of thumb is for someone to be there present in the lab. As I said, for myself as a fellow, that was part of my training to be present with the bronchodilator on hand in case there was an adverse reaction. But a trained clinician should be readily available as the patient's having the test done. To be able to recognize, if the patient has severe bronchospasm, to have a short-acting beta agonist inhaler, a nebulizer immediately available, and for a physician to be available in the facility to be able to respond. So the risk of severe bronchoconstriction of happening obviously is a course much worse if you have baseline airflow obstruction. And since this is a second or third line test, it really should not be used in people with known severe obstruction. So cutoffs vary, but in general, the test should be avoided for patients with FEV1 less than 70% predicted or absolute value less than 1 to 1.5 liters. So I think, again, severe bronchoconstriction can happen, but rare. Definitely have someone available in the lab with a SABA nearby. There's also a very rare risk of cardiac events, but only in patients with truly unstable baseline cardiac disease. So I think a good rule of thumb would be to avoid testing like this 3 months, for at least 3 months after an acute cardiac event, but most patients will tolerate this just fine.
Awesome. Thanks, Monty. Yeah, there's no reason to do this test in someone who has known fixed obstruction at baseline because we can judge airway hyperresponsiveness in a different way for those patients, and there might be a little bit more risk. Okay, Monty, this has been great. Can you give us a summarized list of your pearls for methacholine challenge testing?
Sure. So, Pearl 1. Methacholine challenge is a direct test of airway hyperresponsiveness with relatively high specificity but variable sensitivity, so it belongs inside a diagnostic pathway, not a standalone yes/no asthma test. I'd say Pearl number 2, most useful for symptomatic patients with normal spirometry and no bronchodilator response, and fits best in algorithms where it follows spirometry, bronchodilator reversibility as a first step, the second step being pheno and peak flow variability. I'd say Pearl 3, technique and medications matter. So we're using a tidal breathing protocol. And we remember you have to respect those washout intervals, especially the 7-day washout for LAMAs and the 24 to 48 hour window for LABAs to avoid false negatives. I'd say Pearl number 4, generally a safe test, but can induce significant bronchoconstriction. So again, having that SABA on hand, having someone readily available to be able to respond to the patient, and the test should be avoided for patients with obstruction, specifically with an FEV1 less than 70% predicted. And last Pearl of the day, a negative test, so PC20 greater than 16 milligrams per milliliter, strongly argues against current asthma. A positive test raises the probability but isn't specific and has to be interpreted alongside the clinical story and other objective data for your patient.
All right. Love it, Monty. Thanks for those pearls. We, yet again, probably didn't meet our 15-minute goal for these pearls episodes, but hopefully still short and high yield and high impact for you all. We'll put in the links to the show notes, some links for further reading. But thank you all for tuning in and listening to Pulm Peeps. We'll see you next time. This episode was written with the help of George Doumat, one of our associate editors, produced by myself, Christina Montemayor, and edited help with Dustin Latimer, one of our new Pulm Peeps team's members. And the music is original music by Eric Rogers. Thank you so much for listening. We'll see you next time.